to start off by thanking the Pennsylvania Medical Society for inviting me. I'm a relative newcomer to the state of Pennsylvania. I've been with the University of Pennsylvania now for about a year, a little bit over a year and a half. And I've been asked to talk about alternative therapies and pain management. Obviously, it's a very wide spectrum of therapies. So I've tried to narrow it down and concentrate a little bit more on common therapies that are available to chronic pain patients. Okay. So, obviously I had to narrow this down for a talk of 15 or 20 minutes. So I'm going to give everybody a brief overview of three modalities that are somewhat commonly used. That are alternatives to pharmacological therapy, including opioid therapy. Obviously, they have variable levels of evidence. I'm going to talk a little bit about acupuncture, spinal manipulation, specifically chiropractic therapy, and exercise therapy, specifically as it pertains to lower back pain, arthritis in general, and fibromyalgia. So why do we need alternative medicine for pain? Obviously, we're all here. The opioid epidemic here is obviously a big issue. I've seen patients, I see patients every day in clinic coming in being prescribed opioids for very minor things for a long period of time. As an example, just yesterday I was in clinic and I had somebody come in who had a simple tooth extraction and had been given a month's supply of Percocet, 90 tablets. So obviously that's a pretty big issue. And there are a lot of modalities that are available for chronic pain patients, and they're usually underutilized for various reasons. So some of the complementary things that I want to talk about are basically things that we can add in addition to some of the more traditional Western type medications or modalities that we have. For example, for what I use, interventional therapies, pharmacological management. We can complement these with other modalities, specifically things like acupuncture and physical therapy. And basically what we try to do is balance it out so that patients have multiple things available to them so that they don't rely on opioid medications as much. And again, I'm going to have to narrow it down a little bit, but here's a general list of modalities that are available for patients. All of them are obviously not for chronic pain patients, and there's some that are, and those that are, there's some modalities that show robust evidence for use, and some that are not. And one of the main reasons we're pushing for alternative type modalities for pain is that there are a lot of people that actually believe in it, whether it's as a secondary issue because Western modalities have failed them. So, for example, the latest numbers that I have from 2007 show that 83 million Americans had used some form of complementary and alternative medicine. More than 30 billion was paid out of pocket for it. And it's not only here in the U.S., but also worldwide. A lot of people are turning to what's considered alternative type modalities. In England, for example, a one-year prevalence of about 40% and a 51% lifetime use of complementary medicine. And the main issue is that most people that use complementary alternative type therapies use it for chronic pain issues. There are other reasons, obviously. People that want to try to quit smoking sometimes go to acupuncture, but the majority of people that seek alternative or other forms of therapy, non-pharmacological therapy, is usually for chronic pain. So the first one I'll briefly talk about is acupuncture. The traditional Chinese view of it, or the traditional Chinese medical view of it, is that health is brought on by a balance between yin and yang, and any kind of disruption to that balance leads to disease, and in our case is chronic pain and pain in general. And so basically what the reason of using acupuncture is to kind of bring that balance back and ultimately lead to better health. And basically what acupuncture does is it uses needles to stimulate points under the skin to release this energy that's called qi. And ultimately the qi travels through these channels called meridians. And here's a picture of those meridians. And again, this is more on the traditional Chinese view. These meridians haven't been found anatomically, but there's a picture of those meridians for you. The evidence for it is somewhat robust. There is some evidence of benefit in the moderate range, mild to moderate range, more so in some chronic disease states than others. So, for example, things like pelvic back pain from pregnancy, some types of generalized chronic lower back pain, nonspecific type back pain, headaches, osteoarthritis of the knee. It's been shown to be somewhat successful, moderately so, in some forms of post-surgical nausea and pain. Neck disorders such as myofascial pain, chronic whiplash injury, but in general, for more diffuse generalized pain, the evidence is a little bit more, it's a little bit lacking. But there is definitely some evidence for some chronic pain states. A lot of the literature has its problems, especially when this first became, when it first got into the mainstream back in the 90s. There was problems with publication bias, which is, it's pretty rampant throughout medicine in general. But a lot of positive studies were initially published. Over the last 10 years or so, those it's been balanced a little bit more with more negative studies. There's some studies that show that sham acupuncture is equal to acupuncture itself, or basically putting the needles in non-traditional acupuncture places. There is some benefit to that as well. And newer studies are using blinding to show better evidence, as now there are non-penetrating needles available for some of these studies. So this is kind of a picture of more of the Western view of what acupuncture actually does. There is some evidence that any kind of stimulation from these needles, whether they're at acupuncture sites or not at acupuncture sites, cause a whole bunch of physiological changes. Here's a small list of some of them. And interestingly, the classical studies brought on by that were done through acupuncture, there was one study that was really interesting where they took two animals, hooked up their circulatory system, gave one animal acupuncture, and there was pain relief associated with experimental pain in that second animal. And the thought is that the acupuncture or the needle stimulation was doing something or causing the release of something that circulated throughout both animals, causing some relief of pain. And ultimately what was found was that was endogenous endorphin. There was studies later on that used naloxone to block the endogenous endorphins, and the benefits of the acupuncture were actually reversed. Newer studies as well show that acupuncture may increase mu-opioid receptors in parts of the brain that govern pain. And newer studies are also showing that there's other biochemicals that are released, such as adenosine, that are also involved in analgesia. Functional MRI and PET scans show that acupuncture may actually change patients' brains back to a more normal pattern. And acupuncture actually enhanced descending pain modulation as well. So things like Cymbalta, for example, which we use a lot in chronic pain, which work by enhancing that descending pain modulation. Acupuncture may do that to some extent as well. So the adverse effects with acupuncture, they're very minimal. Minimal in the sense that they're usually not life-threatening. The more common one, usually bleeding. Obviously, you're putting needles. You can get little bleeding, hematoma. These are very tiny needles, very small gauge needles, so the bleeding is very minor. Things like vertigo, nausea, vasovagal responses are somewhat common as well. Much like someone getting an IV can get a vasovagal response. Pain associated with having multiple needles put in, and then less common risks of pneumothorax and nerve injury. There's actually a study done in Germany looking at 230,000 patients undergoing acupuncture, and the most common adverse effect was bleeding at about 6%. And it was very minor bleeding. All the other ones were less than 1%. So less than 1% of vasovagal responses, less than 1% of pain. And pneumothorax, there were only 2 clinical occurrences out of the 230,000 acupuncturists that were done. So they're very minor adverse effects. So there is some benefit with minor side effects. So it's probably a modality that's worth at least trying in some patients, especially if something, for example, that their insurance covers, which unfortunately not all insurance providers do. This is just a picture of the quantitative numbers that they obtained in that study, showing that most of the adverse effects are extremely uncommon. Second modality I want to briefly look at, physical therapy, exercise therapy. Again, This is used a little bit more often in acupuncture. Most providers or most insurance providers do cover physical therapy to some extent, some more than others, obviously. But the main thing that I want to emphasize on this is that a lot of the times we send patients to physical therapy. They come back, and all we ask them is, "Did you get any benefit from it?" And they say no. And if you ask them in a little bit more detail what was actually done, there's a lot of variety with physical therapy. So you can send somebody to a physical therapist who's very hands-on, is setting the patient up on a program for home exercise use, is using different modalities at the physical therapy location. And there's other physical therapists who are seeing 10 patients at a time. Patient comes in, they just throw on a heat pack, do a little bit of ultrasound, and send the patient home. And obviously the results that you're going to get from those two different physical therapy modalities are very different. So what I'll look at briefly with physical therapy and exercise therapy, I want to look at lower back pain, arthritis, and fibromyalgia, which are very common chronic pain syndromes that are typically treated, whether there's some evidence or not, with opioids. The physical therapy, you can break it down into two sets. You can do aquatic therapy or traditional land-based therapy. Most of the studies comparing both of them show that they're about the same. The benefit of using the aquatic therapy is that because of the water, you get some buoyancy, and that takes a lot of pain and pressure away from patients that are very sensitive and can't actively participate in physical therapy. So nobody really knows how physical therapy may work. There's usually multiple mechanisms of action. One of them is that it may desensitize our hyperactive nervous system. In general, chronic pain patients usually move less because they hurt, which leads to deconditioning, and then the deconditioning itself leads to worsening pain. So the goal is to try to break that cycle, usually with very mild physical therapy initially, and then ultimately getting them to a state where they can actually do exercise at home and kind of incorporate that into their lifestyle. And the benefits of that early on are important. So a study in Denmark looked at 600 kids and followed them for 25 years and found that those that were physically active for about 3 hours a week or so had a lower lifetime risk of back pain. Another study in Norway of over 40,000 people found that those that exercise had a much lower prevalence of chronic pain in general, not only back pain, but chronic pain in general. All right, so those with chronic lower back pain often avoid exercise out of fear that their pain will get worse or make things worse. So that's one thing you want to promote. If you're prescribing physical therapy for a patient, a lot of them are scared because they're hurting, and you're going to send them somewhere where they're going to hurt even more. So a lot of the times they'll go for one session, come back and say, "I can't do it." And so what you want to do is you want to find if you send people to physical therapy consistently, it's probably good that you find a good physical therapist that you know very well and can work with. And ultimately, you want to have the patient start off very slow and kind of move up. If even land therapy is very light for them and it's still causing them a lot of pain, it may be better to send them to aquatic therapy, get them conditioned a little bit, and then ultimately transfer to land therapy. A study of 1,500 patients with lower back pain found that those likely to be in pain 6 months later were those that had significant fears of moving. So again, you want to get them moving as early as possible. And studies show that the more fear people with back pain have about moving, the more pain they report during activity. And then the ultimate thing is you need to change these beliefs early on, and often this is very, very difficult. So exercise helps reduce lower back pain, but what exercise would you prescribe? And obviously, I have a lot of patients come in and they say, I don't need to do physical therapy. I go to the gym every once in a while, but that's not the same thing as having supervised therapy. They may go to the gym and be doing things that they probably shouldn't be doing, which will exacerbate their pain. Ultimately, they don't want to do anything else, and that kind of cascades down to even worsening pain. And so usually I like to have patients have some kind of supervised approach, see a good physical therapist so that they can set up a program where once they're done with that physical therapy, they can continue that and incorporate that into their lifestyle. And obviously, that's a lot easier said than done. So what kind of training would you prescribe? A lot of the times, most people will just write physical therapy, evaluate, and treat. But ultimately, you want to kind of guide the physical therapist unless it's somebody that you have a really good relationship with. Usually for chronic lower back pain and back pain in general, Recommend strength training and resistance training. Obviously, most people can't do that early on if they have severe pain. You want to do exercises that improve lumbar stabilization. You want to have an intensive exercise program at some point for more than 20 minutes at a time, which is key. And obviously, this must be tailored individually, um, and usually not early on. And then aerobic exercise for chronic lower back pain has mixed results. The aerobic exercise itself may not help the actual chronic lower back pain, but if you can get them into a weight loss program, for example, in somebody that's obese, that in and of itself may lead to improved lower back pain. Yoga is another thing that a lot of patients will come and ask about, and the studies looking at that have mixed results um, in regards to at least lower back pain, and there is some evidence that it may actually lead to further injuries, and the reason for that probably is because nowadays you can get a yoga DVD and just do it at home, and if you're not doing it correctly, then obviously that can lead to problems down the line. And the most recent guidelines from the American Physical Therapy Association recommend manual therapy, trunk coordination, and endurance exercise as well. But the main thing with any kind of physical therapy is that you want to plant that seed early on that this is going to be a lifestyle change. It doesn't make sense to send somebody for physical therapy for an hour twice a week for 4 to 8 weeks, and then they come back and they may have had some relief initially, and they'll tell you, yeah, it worked for a couple hours after physical therapy, but then the pain slowly came back. What you want to do is you want to instill that and also with the physical therapist, that they should be developing a home exercise program that the patient can kind of incorporate into their life and continue that even after their actual physical therapy sessions end. Exercise for arthritis. Both osteoarthritis and rheumatoid arthritis tend to be diffuse, and usually the last things that patients want to do is exercise. And both land and aquatic therapy can be good for both rheumatoid arthritis and osteoarthritis. 2009 review of 8 studies in rheumatoid arthritis patients concluded that both aerobic exercise and strength training improve pain and function without causing damage. And that's a lot of the times, especially patients that have osteoarthritis of their knees and their hips. A lot of them are worried that they may actually be doing more damage than good by doing any kind of extensive exercise. And if the exercise is done correctly, the chances of causing any damage downline are not significant. A couple of trials showing that if the patients are obese and have knee osteoarthritis, both losing weight and the exercise itself will yield better than either one alone. And another key to kind of stress is that patients with knee or hip OA that kept exercising after 5 years of follow-up had less pain and better functioning than those that didn't. So again, you want to have them incorporate that into their lifestyle rather than just sending them for a few weeks of physical therapy and ending it there. Exercise for fibromyalgia. Fibromyalgia is the mechanism or the pathophysiology of fibromyalgia is getting elucidated more and more every day. Initially, it was obviously thought that it was mostly a psychological dysfunction, but it's more research is showing that there is some biological problems associated with it, mostly central sensitization and a problem with the patient processing pain. There usually is obviously some psychological factors associated with it as well. And exercise for fibromyalgia is key. It's probably better than any kind of treatment you can offer these patients. I've seen patients on ridiculous amounts of opioids. I had a patient. I was in private practice in Virginia before I was at the University of Pennsylvania. I had a patient referred to me with fibromyalgia who was on over 1,000 milligrams of morphine a day. And of course, their pain was still 10 out of 10. They weren't sleeping, they weren't functioning, and so obviously opioids haven't really been that successful in treating this patient population. But what has been is exercise, and just like Dr. Goldenberg notes here, I think he's a Harvard physician, that exercise is one of the best things, perhaps even the best thing a person with fibromyalgia can do to decrease pain, improve mood and function, and restore quality of life. And again, that needs to be stressed to a patient with fibromyalgia. A lot of times we just use that as a secondary thing, like, oh, you need to go do some exercise and move around. But if you can kind of plant, again, that seed where this is the treatment for it, not humongous doses of narcotics, the benefits are going to definitely outweigh the risks. Aerobic program seems to work best. There's a meta-analysis looking at over 3,000 patients that have fibromyalgia, and their strongest support was for aerobic exercise. Not only did it improve pain, but it actually improved the secondary things that we see in these patients, such as fatigue and insomnia. And then Tai Chi has been shown to have some beneficial or some benefit as well. Most of those studies looking at Tai Chi and fibromyalgia patients are very small, but there are improvements in both pain, mood, quality of life, as well as sleep. All right, and then the last thing I'll talk about is spinal manipulation for chronic pain or chiropractic therapy. There's various definitions of it. It's been around for over 2,000 years, described in ancient China back in the 2500 BC era. But basically, the main way it's described is the method of applying controlled force to a joint and moving it beyond the normal range of motion in an effort to restore health. And studies looking at that specifically for chronic lower back pain are mixed. There is some benefit when you compare them to some medications, for example, like anti-inflammatories, especially in the short term. There's others that don't show any benefit over anti-inflammatories or other medications. There's a lot of variability in the studies looking at chiropractic therapy for chronic lower back pain, and a lot of it is very heterogeneous, so it's very hard to kind of pool that kind of data. There are some studies that show that to maintain improvements in reduction of pain, the manipulation must be continued long term. And a study from England showed in over 1,300 patients that manipulation is better than regular care, but only if combined with exercise. So again, the exercise part is key. A more recent 2013 review of systematic reviews looked at 6 systematic reviews that assessed chronic lower back pain and chiropractic therapy, and noted that 3 of them showed some positive benefit and 3 of them did not. So I'll end it there. I left 20 plus references. If anybody wants references on some of this information, let me know. But the main thing is that things like exercise, physical therapy, is that you want to really get that into the patient's head that it's more than just a quick therapy that they go to a couple times a week. It's something that they really need to continue as a lifelong process.